My friend Dr. Anand kUMTA was not able to come because of some personal reasons, so I'll be presenting his talk. This is again a talk on ultra wide field autofluorescence with the same machine which I was talking about. So we'll just look at a case where a 67-year-old presented with diminished vision in both eyes for 2 years. His vision in both eyes was 618. There was no systemic illness. This was his clinical picture. He was diagnosed elsewhere to have CNVM in both eyes and treated with multiple anti-VEGF injections with poor response. You can see here that there are RP changes right at the fovea in both eyes, almost similar picture. And this is his OCT picture where you can see that there is subretinal fluid, some RP changes, intraretinal cystic changes. But if you do an FAF, you can see this is a classic CSR picture. You can see this gutter-like changes here in both eyes and speckled changes in the foveal area. So this is a CSR and not a typical CNVM. So autofluorescence allows you multiple disease entities to be characterized in a particular manner. You can have the VK edge, multifocal pigment placoid choroidopathy, melanoma, atrophies. All these have various patterns, and if you understand them well, it can help you in your day-to-day practice. So we have talked about these things. Here in the autofluorescence mode, we use the green wavelength of 532 nanometers. Now, basically in autofluorescence, the lipofuscin pigment is the important pigment which is located in the RP. It is the most dominant fluorophore, and it is basically a metabolic waste of the photoreceptors. It is indicative of oxidative cellular stress, and it is increased in degenerative disorders like AMD, macular dystrophies, Best and Stargardt disease. So in all these situations, autofluorescence is important in uveitis, drug toxicities, optic nerve drusen, chronic CSRs, in choroidal nevus, macular dystrophies, RP, AMD, and in certain cases of unexplained visual loss, it will be very helpful. And now we'll be seeing some examples of all these. So basically, because ultra wide field imaging itself allows a wide imaging of the retina. So in the picture on your left, you see that you hardly see any RP changes in this patient. But if you take an ultra wide, you'll see that the whole of periphery shows RP changes. So it's important that you have an autofluorescence and you have an ultra wide field autofluorescence. So typically in an autofluorescence mode, the optic nerve would look dark because there is no RP or lipofuscin there. Then the fovea center would look dark because again there are no pigments. The blood vessels look dark because there is absorption by the blood of the pigment. Then periphery looks grayish, and parafoveal area there will be mild decrease intensity because increased melanin content and lower density of lipofuscin in the central RP. So the abnormal autofluorescence is because there is a change in the amount of composition of fluorophores in the RP cell cytoplasm, and there is absorbing or autofluorescent material anterior to the RP. So we have a term called hypoautofluorescence, which are dark areas, and hyperautofluorescence, which are bright areas. So if there is hypoautofluorescence, that means the RP are dead, and you can get a typical dark, punched out dark area of hypoautofluorescence, or there is blood absorbed signal because of interference by blood, pigment, or another blocking artifact. So if you have an RP atrophy, you get this picture. Laser scars will look like this. And if there is hemorrhage blocking the retina, you will see again a dark hypoautofluorescent patch. Drusens will different forms of drusens. Hard drusens will be where there is RP atrophy associated with it. You will get dark hypoautofluorescent areas. Exudative lesions again will produce a dark areas. And if there is dense hyperpigmentation, again you will get dark areas. So basically, if there is hyperautofluorescence, that means there is excessive lipofuscin, and that indicates sick or increased activity of the RPE. So here you have yellow lesions which will look hyperautofluorescent. Soft drusens usually look hyperautofluorescent. Bullseye maculopathy, very typical. Center will be hypo and a peripheral ring of hyperautofluorescence. And old hemorrhages which are organized will become hyperautofluorescent. So in short, dark is dead and bright is sick or increased metabolic activity. In posterior uveitis, it is very useful because in an active stage, you will see that there is a margin of hyperautofluorescence along this edge. You can see clinically also there is white areas all around. As it starts healing, some of the areas become dark and some are still white. And in heat stage, most of them become dark. So looking at this image of autofluorescence, you can see how the patient is behaving and how the uveitis is undergoing changes after your treatment. So it is highly sensitive in differentiating active versus inactive lesions. As you can see here, it looks almost inactive, but this area here shows some activity which is seen very well on the AF image, where this area is hyper autofluorescent, indicating there is still some activity here, whereas rest of the areas is dead RP. Similarly, here some areas are healed, some are still active. You can see this by the whitish areas, hyper autofluorescent areas mixed with the hypo autofluorescent areas. Whereas later on it is all hypo, there is no hyper autofluorescence, indicating that it is resolved. Like in cases like Medusa, you can see that multiple hyper autofluorescent spots, and after 6 weeks without any treatment, it has cleared up. Similarly, here the lesions in a active stage, you hardly see any lesions, but if you do an autofluorescent, you will see many areas of hyper autofluorescent indicating activity. And again here, clinically not much seen, but here you can see an extensive areas of hyper autofluorescence indicating the inflammatory areas. So in VKH also it is helpful, because here again this area almost looks normal, but on autofluorescent you can see it's an hyper autofluorescent, and total area can be delineated where there is activity, and which over the period of time heals, and after resolution it is almost cleared up. Similarly, in this case, extensive hyper autofluorescence is seen, which clears up after resolution with your treatment. It is very useful in determining optic nerve head drusen, as you can see here. In the here you can just see a bumpy disc suspect, but here it is very clear that there is no doubt that there is optic nerve head drusen, and it helps in differentiating from in pseudo papilledema. As you can see here, this is a true papilledema, and this is a pseudo papilledema due to the optic nerve head drusen, again seen here very clearly. In cases of drug toxicity also it is helpful, because in color images drug toxicity changes are sometimes missed, but if you do an hypertension, you can get a typical bullseye maculopathy with a central hypo surrounded by an hyper autofluorescent ring. So in cases of drug toxicity like in hydroxychloroquine, didanosine, thyroidazone, teferoxamine and tamoxifen, all these conditions you can see this bullseye maculopathy, which helps you determining whether the patient is reacting to it or not. And you can compare it with OCTs also. As you can see the changes here in OCT, and in autofluorescence you can see them much better. Again, if there is a distorted vision for 2 months, vision is low, and patient is on tamoxifen for 5 years, you do an FAF and it can be very clearly seen. In cases of CSR also it is very helpful, because the dark granular area is indicating serous sleep and hyper autofluorescence seen, and you can see a typical tracks here which are very classical of chronic CSR. If you have bilateral chronic CSR, clinically you don't see much changes, but if you do an autofluorescent image, you can see very well that there is extensive changes in the RP. Similarly, in this you can see the tract which is not clinically seen, but with hyper autofluorescence you can see the extent of the changes. In ARMD again, clinically you see very fine changes in the center, but with autofluorescence you can see the extent of the changes because of dry AMD. It helps in indicating the geographic atrophic areas also very well. And along with this, it's you can see the dense areas which are totally gone, whereas rest of the areas are unhealthy, and see the extent how big it is. So you can differentiate into various types of hyper autofluorescent images based on the characteristic reticular, branching, fine granular, trickling and GPS. Geographic atrophy also helps in larger areas of the central macula being involved. We can exactly mark out how much atrophy has occurred. And if you have an hyper autofluorescent margin to it, you know that this is going to progress. In retinal dystrophies also you can use this to exactly see what changes are, right? You can see there's a hypo in the center with a surrounding rim of hyper autofluorescence like a bullseye maculopathy. And in this some certain patients, like this patient of 56-year-old male, where there's a diminution of vision in the bright illumination and difficulty in color appreciation, you do an autofluorescence image, you can see the bullseye maculopathy very well. In Best dystrophy, you can determine the various stages. Now, this is a vitreoeruptive where you have some areas of hypo and some areas of hyper. Whereas in the vitelliform, you can see a typical white lesion as a moon sign, which is indicative of this particular stage. In Best dystrophies, again, when in a healing stage, you can see there is a hyperautofluorescence ring to the hypoautofluorescent center. In pattern dystrophy, similarly, you can see an hyperautofluorescent center. And you can see the changes. One eye has hyper and other eye is now going into hypo stage. Similarly, for butterflies, pattern dystrophy, you can make it out very well, which clinically not very well seen. Stargardts, clinically you hardly see any changes, but here you can see them very well. And over the period of time, they from hyper auto they go into hypoautofluorescence. Similarly, in retinitis pigmentosa, you can document the changes. Clinically, you see the typical bone spicule, but you can see the extent in autofluorescence. Extensive damage, only the central field is remaining, so you know that the patient has tubular vision only. Again, vision may be good, but extensive changes may be seen on high autofluorescent imaging. Similarly, here, extensive changes. It will also helpful in cases of paravenous pigmentation, where you can make out this pattern very well, which clinically is not very well seen. Other very important application is to differentiate between the choroidal nevus, congenital hypertrophy of retinal pigment epithelium, and choroidal melanoma. So, in choroidal nevus, as you can see, if you do an autofluorescence, the nevus lesion would disappear because it is below the RPE. In congenital hypertrophy of the retinal pigment epithelium, you'll see it more prominently seen. It becomes hypoautofluorescent because the RP is dead there. And in choroidal melanoma, you can see that the drusen-like image substances would cause hyperautofluorescence. Rest will be hypoautofluorescent. So choroidal nevus, as you can see, clinically is seen here, but it disappears on autofluorescence. And otherwise, it becomes in choroidal CHRP, it becomes more prominent hypo. And in melanoma, again, you have wherever there is deposition of lipofusion, you will see them as hyperautofluorescence. Conventional laser marks, you can see them extensively. You can differentiate them with the multi-spot laser. So you can make out what type of laser was done, whether it was adequate, whether there skip areas. So to conclude, I think if you are doing a retinal evaluation and if you have this technology, it is very important that you should screen most of the patients with this because it gives you a lot of information which is not clinically seen. And it tells you the metabolic state and overall health of the RP and allows detection and analysis of many pathological and retinal conditions with peripheral findings. Assessment and progression of follow-up of many retinal conditions is possible, and lot of conditions which are clinically invisible become visible with FAF. Thank you for your patient hearing.